Visualizing the obscure, chromophore-assisted retinal break detection. In today's era, vitreoretinal surgery has seen improvements in technology, use of small-gauge instrumentation, and improved visualization systems. Despite these improvements and as well as the use of flawless surgical skill and techniques, about 10% of cases still require repeat pars plana vitrectomy for recurrent retinal detachments. Proliferative vitreoretinopathy or PVR is the most common cause of recurrent retinal detachments. The other cause for recurrent retinal detachments are retinal breaks, especially missed retinal breaks. According to a study, missed retinal breaks are the reason for 64% of failed RD cases. Missed breaks in recurrent retinal detachments can be challenging to detect due to prior laser scars, pigmentary changes or lack of contrast from the choroid. We describe a technique of occult retinal break detection, where BBG dye is injected into the subretinal space with a 41-gauge cannula and the plume of the dye emanates from the occult break. We demonstrate the use of this technique in the next few videos. A 62-year-old male presented with decreased vision in the right eye. He underwent pars plana vitrectomy for rhegmatogenous retinal detachment 3 months back. The right eye vision was hand movements and anterior segment examination revealed pseudophakia. There was no view to the fundus. B-scan revealed dispersed vitreous cavity hemorrhage and retinal detachment. He was planned for a repeat vitrectomy. Intraoperatively, a retinal break could not be localized and hence subretinal injection of BBG dye was thought of. BBG dye was loaded in the subretinal injector and the injection pressure was lowered. A 41-gauge needle was used to inject the dye in the subretinal space. PFCL was injected to displace the dye to the retinal periphery and the plume of the dye was noticed emanating from the now visible break. We show this again in slow motion. A relaxing retinectomy was done followed by endolaser, fluid air exchange and silicone oil injection. Three months post-operatively the retina was attached under silicone oil. We use this same technique in another patient where we inject BBG dye in the subretinal space to visualize the occult break. We should make sure that there is no air in the injector or there will be an inadvertent injection of air bubbles in the subretinal space as you see here. rest of the surgical steps were similar to the first case. 3 months post-operatively the retina was attached under silicone oil. In another case of recurrent retinal detachment, after peeling the PVR membrane we injected subretinal BBG to search for occult break and found none. We drained the subretinal fluid after making a draining retinotomy. We used BBG dye, which is the least toxic to the retina as compared to trypan blue or indocyanine green. One study utilized the transscleral route of trypan blue dye injection, which can have potential complications. Only 2 other studies exist in literature utilizing trypan blue dye for subretinal injection to detect breaks in primary retinal detachments. To conclude, subretinal BBG dye injection is useful for occult break detection as it provides a color contrast. It helps in avoiding a posterior draining retinotomy and is useful in recurrent detachments where it is difficult to localize a break. We used BBG, which is least toxic, and report its use for this purpose in Indian eyes.